Okay, perfect. Okay, so we'll go ahead and get started. Thanks again for supporting this series. I'm gonna go ahead and share my screen. Okay, so this is Intro to Vents Part 2. We're going to be talking more about different problems that can show up with the vents and different ways to see how your patient's doing. If you forgot everything in the first session, that's okay. I probably did too. I sent out the recording and all the slides to all your emails. So we're going to start off with another Kahoot. Again, this is eventually going to be used for like research purposes. So if you don't want that, then you don't have to. Just ask if you do participate to keep your name the same before and after, so I can keep track of scores. Okay. Who's the last person? Because there's only 5 of you. I'm sparing none of you. Who is it? Okay, let's okay, let's get started. Okay, awesome. Okay, great. So that was just the poll, and then at the end we'll talk about the right answers, all of which should be explained within this presentation. Okay, so for the first section, we talked about just the basics of ventilation, the mechanics, different types of modes that you would use, and kind of like the physics behind those types of modes. And today we're going to talk about how to see how your patient is doing when they are in a ventilator, and also just talk about a selection of very common problems that would arise for patients that are ventilated. So I wanted to start off with just how is the patient doing? And the way we kind of divided this was just when you walk into the room, how can you assess whether something's wrong or whether the patient's doing well or not? And so first off, I just have like one at bedside. So their general appearance, physical exam, are they wheezing when you take a listen? Are breath sounds absent from one side? Is the ET tube out? Stuff like that. And after that, we divided it into mechanical and physiological. So mechanical being purely something that you can find out by looking at the vent. So we're talking about high or low peak pressures, plateau pressures, if there's auto peak, which we'll discuss later in the presentation, if there's like an alarm going off in the vent, those kind of examples. And then on the other side, more physiological stuff. So what's actually happening in the tissue. So we're going to look at how to interpret the pulse ox, capnography, or the CO2 waveform. And you can't really get an ABG just by walking to the room, but eventually, if you get an ABG, we'll talk about those numbers and how that would correlate to whether you would change your ventilator settings or not. And the culmination of all of this, which all of you got on the pretest, is the spontaneous breathing trial. So putting someone on very, very light ventilation settings and just seeing how they do. And that's the best way to see if they're ready to come off of ventilation eventually. Okay. So this slide is exactly the same slide from the first session. I just wanted to put it here because it's kind of complicated and also very important for this session. So again, this is just the pressure waveform, which is usually at the top of your ventilator screen. As the ventilator forces air into your respiratory system, your pressure is going to go up until you hit the peak pressure and then come down with expiration. And something we do want to look for is something called a plateau pressure, where we do an inspiratory hold. You stop the flow of air coming from the ventilator. You allow all the gases to equilibrate across your respiratory system, and that will give you a representation. That will tell you the pressure at your alveoli. So basically, you're checking to make sure that you're not causing any barotrauma to your alveoli. And the way you have to do that is to stop the flow and allow the gases to equilibrate. So the pressure you measure at the end of the ET tube is going to be the same all the way down to the smallest portion of the lung. And the difference between those two is going to be the airway resistance. So last time I only gave you guys one example of how this pressure curve could be changed. So today I wanted to go into some more examples. So this is a picture of your lungs on the left, and then your pressure curve on the right. And let's say last time we talked about if your ET tube was kinked, for example. So let's say this is your ET tube, and you've got a nice little kink here. Or maybe, for example, your patient has a lot of secretions, and they're plugging up your ET tube. Or let's say your patient is having a bronchospasm, and the bronchioles are tightening up. These are all things that are going to increase your pressures. So as the air is being forced into your airway, you're actually going, because it's going through a compromised space, you're going to feel a lot of resistance, right? So your pressure is going to be pretty high as you're forcing the air in until you reach an elevated peak pressure. But the actual amount of air that effectively made it into the system past the compromised airway into this massive lung space is going to be pretty low. So if I were to stop the flow, allow the gases to equilibrate and measure my plateau pressure, it would actually be pretty low. And the difference between those two is going to be your airway resistance. So because you do have something wrong with your airway somewhere along the line, this is going to be a lot larger than normal. Normal is going to be like 5 or so between here. Okay, so let's see other examples. Let's say, for example, your patient has atelectasis. They kind of slacked off on doing incentive spirometry after their surgery. or let's say they have pulmonary edema, or they just straight up have a pneumothorax and the entire lung is out. So what would happen here? So as your air goes in, you are still going to get an elevated peak pressure because let's take the pneumothorax, for example. Instead of pushing air into 2 wide open lung spaces, you're forcing it into only 1, the same volume into 1 lung. So that pressure is going to back up and it's going to lead to a high peak pressure. And now if we were to do an inspiratory hold and look for a plateau pressure, allow the gases to equilibrate, because they're equilibrating in a much smaller space than intended, your plateau pressure is also going to be elevated. But as you can see, the difference between the two is actually pretty normal because there's nothing actually wrong with my airway. It's just the actual lung parenchyma that's forcing these pressures to go up. Any questions on those two before I talk about this table? Okay, so this table is just a summary of the last two. So the first one, what could it be? Something wrong with the actual airway. The second one, something actually wrong with your lung parenchyma. And what I didn't show a picture of was just if both of them are low. So this is just when the vent can't actually generate a high enough pressure to actually deliver a breath effectively. That could be the patient not connecting well, there's an air leak around somewhere. So that's just the third possibility of pressure. Okay. So another thing that we talked about on the slide last session was PEEP, which you all know is the positive and expiratory pressure, the pressure that's still pushing back on the airway at the end of expiration. And instead of going down to 0, like this example has, we usually have patients on a PEEP of like 5 if they're ventilated, just to kind of ease up the discomfort of breathing through a tube. So usually after expiration, you'll see it kind of level off over here. And what can go wrong with this? There's something called dynamic hyperinflation or auto PEEP. And this happens when a patient hasn't finished expiration and the ventilator starts the next breath and just forces the next volume of air right in before the patient has finished getting out the previous breath. So this can lead to increasing volumes because every time that you try to breathe out, you're just getting more and more air in. And you can kind of think of this clinically. So for a patient with COPD, for example, their lungs are just not able to effectively squeeze out all the air during expiration like they used to. So that's why you see things like barrel chest that we saw, that we talked about in like the first 2 clinical years, or maybe like pursed lip breathing, where the patient is still trying to keep their airway open by putting that PEEP on by themselves. And because of these increasing volumes, you are going to also get increasing intrathoracic pressure. There's just more and more building up. So how do you know if this is happening? First of all, you can just look at the patient. Are they wheezing? Are they contracting abdominal muscles? Do they have a history of COPD? You can look at their end tidal volume. Is CO2 building up because the patient isn't effectively clearing each breath? And for the actual ventilator, what you can do is do an end expiratory hold. So instead of an inspiratory hold like we did for the plateau pressure, instead we'll pause the flow, allow gases to equilibrate, and at the end of expiration, we can see that this pressure here is actually increasing. So instead of the PEEP that we set down here, maybe like 5 or whatever, it's going up because of all the extra pressure and volume that's building up from the patient not being able to clear their lungs effectively before the ventilator is forcing the next breath in. So how do you fix this? So the problem here is actually just because the patient can't finish expiration, right? So let's give them more time to do that. And one way we can do that is by lowering the respiratory rate. So instead we give them a longer time for inspiration and a longer time for expiration, or the inspiratory time or I time is a parameter that you can also change on the ventilator. So by shortening that, you will give the patient a longer time to finish expiration without changing the respiratory rate. So those are 2 options that you have to fix this situation. I think another example that Dr. Jafari mentioned clinically was like, if it's really, really bad, you can just disconnect the patient and just kind of like push on their chest and then help them get all the remaining air out. But that's just another example. Okay.
Can I add one thing? In terms of how to diagnose this in modern ventilators, if you look at the pressure curve that is being represented on the ventilator, you can easily see that the nadir does not come back to what you set it at. So if you set the PEEP at 5, but you see that the pressure curve is not coming back down to 5 and stops at 7, then you know you have an intrinsic or auto PEEP of about 2. In some of the ventilators, it actually is being reported breath by breath as a separate measurement as well. So on the output side of the ventilator, whatever the ventilator is measuring, there's one component that is, I think it's called PEEP I, or intrinsic PEEP, I as the small I. And you can look at that and you see if that matches your own PEEP or is within 1 or 2 centimeters of water, then you know that you don't have a significant intrinsic PEEP. On the other hand, if you set the PEEP of 10 and then the machine says that the intrinsic PEEP is also 12, is also 4, then you have a component of intrinsic PEEP. Or as I said, you can just look at the curve that is being the graph that is being plotted by the ventilator and see if the nadir comes back to what you set it at.
Mm-hmm. Yeah, exactly. So this is like a graphical example of what you would see on a vent in someone who's experiencing that auto peak. So exactly as Dr. Jafari said, you kind of get this uptick slowly with each breath as the breaths are accumulating on your pressure curve. And you can also see changes in the flow and volume curves as well. So the flow here, this is abnormal here. So as you can see, this is inspiration with air going in and now expiration with air coming out. And usually this would kind of extend, go down to 0. But here, instead of finishing instead of the patient finishing expiration, the flow is suddenly reversed. So this is the ventilator kind of taking over and giving the next breath before the patient has finished actually expiring. So this is kind of a clue for you on the flow curve. And then also on the volume curve, you can kind of see something similar where you just get that slow uptick in the volume based on the stacking breath. Okay. So now instead of kind of mechanical side of things, we're going to look at the physiological side of things, and the first one being oxygenation. And this is your beautiful O2 dissociation curve from like first year. And the only reason this is here is just to kind of explain the reasoning behind why we react to the pulse ox at certain numbers like we do clinically. So starting off with this, this is kind of like your O2, this is your O2 saturation on the y-axis. And for this example, I'm using the pulse ox as my representation of what my saturation is going to be. And my x-axis is my O2, my pressure of oxygen. And I added this green line here just to show you that a normal pressure is going to be like 75 and up. And when you look at this curve, I'm just using the blue curve here because the red and green are representing, like, for example, if your pH or temperature were to change, it would shift how easily the oxygen comes off. So those are there just for your reference, but I'm going to look at this blue line here. And as you can see, this 75 to 100 is pretty large on the x-axis, but when you translate it to the curve, on the y-axis, it's actually only translating to a pulse ox of like 93 and up. So a 7-unit difference versus like a 25-unit difference. And this kind of changes as you go down this curve and it becomes gradually steeper. So what I mean by that, by the time we hit 90 on the pulse ox, you're actually at a very low level of oxygen here, and so on and so forth. So if I'm down to 80, I'm down to 50 here. And as you go down this curve, down this steep part right here, it just gets worse and worse. So the reason that the whole reason for this graph is just to say that if your pulse ox is dropping to like 93, you should start thinking about what your next steps are. Because once you hit 90, you're at a pretty bad state in terms of the patient's oxygenation status. So to give yourself a little bit of time, we say around 93, kind of start thinking about what your next steps are, what could be going wrong. So yeah, all of this just to say, if the pulse ox is low, do something. But this comes with a kind of caveat. I mentioned at the beginning that I'm just assuming that my pulse ox is the correct representation of my saturation right now. But you should always check for a reliable waveform, which I'm going to talk about in the next slide. And of course, if your pulse ox is at like 50 and the patient's not doing so well, then you would, bag the patient, get a STAT ABG, look for the cause, that kind of stuff. But we're not going to talk about that right now. So what I mean by waveform. So I have a lot of examples of different waveforms here, and the reliable ones are going to be on the left side of the screen and the unreliable ones are on the right. So just starting off with like your basic pulse ox, this is a nice, good waveform here. It's regular. This is a little bit of noise artifact, so it's a little shaky, but you still see the good waves here. And now the key to determining whether so this is called, let me back up a little bit. This is what you would call a plethysmograph, which is a word that I learned in making this PowerPoint. I just never paid attention to that word before. But basically the trick to see if this is reliable or not is to correlate it with it to the heart rate, because this is a pulse ox, right? So you're measuring, you're trying to predict what the O2 is based on the pulse that you're getting through the finger. So it should correlate here. As you can see, this is very reliable because you have a heart rate, and then you see the measurement of the SpO2, heart rate here. They're matching up very well. And in this setting here, it may look like the pleth is kind of all over the place, but if you look at their heart rate, it's actually irregular. So, and if you track it down, it is correlating to the pulse ox measuring the oxygenation status. So even though it looks weird, it's correlating to an irregular heart rate. So this is still reliable because it's representing just an abnormal heart rate in general. So switching over to the unreliable side, this is like, I don't know, the patient's waving around, motion artifact. You don't get a good waveform, or just poor pulse quality if the patient is cold, if they're wearing nail polish, something like that. And then these two graphs here, Dr. Jafari took a picture of. So here you can see that you have a good pleth. It's lining up really well with the heart rate. And then Dr. Jafari, I'm assuming that you like push down on the finger or something, and the pleth flat lines here. So no more good waveform. And as you can see, there's nothing correlating with the heart rate at this point. And then the last one.
I am not that cruel. No, I just got it off of the telemetry. I don't know what was actually happening with the patient, but that definitely is not a reliable pleth.
Okay, so never mind. And then the last one at the bottom, this is the pleth here. You don't really know what's going on with the heart rate, neither does the machine, and it's also putting a question mark. But as you can see, there's no good waveform. It's not correlating to everything, so this would also be unreliable. Any questions about this? Okay, cool. All right, so the next one is capnography. So instead of O2, we're going to be looking at CO2. Nothing special here. It's just this is the CO2 as they're inspiring, it's going down, and as they're expiring, it goes up, which makes sense. And at the very end of it, that's where you're going to measure your end tidal CO2. And this is just how it would look like, this bottom row here on your vitals. So what could go wrong with this? Same thing. You can get just no waveform at all. Patient could actually not be being ventilated, or the tube is disconnected, it's kinked, the CO2 sensor isn't working. Those are all reasons to get kind of a bad waveform. And other things that can go wrong are, so what I'm going to show for this next set of slides is the difference between your PaCO2 and your end tidal CO2. So assuming you have like that little end tidal CO2 monitor that you can put on the patient's mouth versus like a PaCO2 that you get from an ABG. And there's a normal arterial alveolar gradient between the two. So this will normally be about 3 to 5. And I'm going to show you different ways that this line and this curve can change in relation to each other. So first off, we're going to see if both of them are increased. So usually your PaCO2 and your end tidal are going to go together, right? So for this example, both of them are high. So the patient is hypoventilating. They're accumulating CO2. So they're going to go together. Both of them are increased. The patient isn't effectively breathing out the CO2. And on the other side of things, both of them are low. Patient is hyperventilating. They're blowing off too much CO2, so the PaCO2 and end tidal are both decreased. So normally that gradient is going to stay the same, because the two values are going to move together. Another thing that can actually go wrong though is when that gradient increases. For example, if your end tidal decreases, but your PaCO2 is actually elevated or stays the same. So this space in between the two is now larger than normal. And this usually happens if you have pulmonary dead space. For example, the CO2 in the blood is unchanged, but it's not effectively making it outside of the patient's lungs because there's a PE or something else going on that's affecting how much the lungs can effectively clear out CO2. And this is just a table summarizing that based on which direction the EtCO2 and the PaCO2 are going, the reason for that, different causes, and then just the color of the waveform based on this PowerPoint here. Any questions on that? Okay. So before I go to the next section of this, I just want to give you guys like a set of what usual vent settings look like. And usual is in quotations because obviously there's going to be a lot of settings that affect what your ventilator is. If it's not this, it doesn't mean that the patient is, you know, doing poorly on the ventilator, that you're doing something clinically incorrectly. It's going to change based on pathology, the patient's medical history, everything. So this is just a guide for what I mean when I say that something is going wrong. But again, take that with a grain of salt based on your clinical scenario. Okay, so I could just go through them here. Tidal volume being 6 to 8 milliliters per kilogram based on predicted body weight. Remember, if the patient gets fatter, the lungs will get bigger. So that is on predicted, which is just a table you can find. Peak is usually less than 40, plateau less than 30, area resistance about 5. PEEP is usually 5 to 8, again, just to compensate for how uncomfortable it is to breathe through a tube. The gradient we just talked about, 3 to 5, and then I have the ABG values that you would normally see. I got these off Centerized, so. Okay. So if you take nothing away from this PowerPoint, this is the only slide. So if you're sleeping, just wake up, read this, and then go back to sleep. But perfect settings and lab values are not always good for the patient. That is kind of like the only thing that, okay, not the only thing, but the most important thing to come out of this lecture. And the way that I wanted to talk about that was through some ABG examples. And we're going to walk through some scenarios and then kind of decide, are we going to change the ventilator or not? And because there's only 5 of you, I'm going to ask that you participate, if that's okay. So first off, all right. So full disclosure, this is actually the hardest part of PowerPoint for me to wrap my head around, just because there's just so many like little rabbit holes you can go down. But what I want to present this as is there's obviously going to be metabolic respiratory components to different disorders, but keep in mind that this is a ventilator lecture, so I'm only going to focus on the respiratory part for you. So first case that we're doing is 50-year-old man, height of 6 foot, weight 68 kilograms, and just to keep it simple, no past medical or surgical history. And he's febrile to 102, hypotensive to 160, tachy to 100, a respiratory rate of 45, and satting at 90 on room air. And there's your ABG below. And if you need it, the values are in the corners there. So just based off of this, can anyone give me an example or a thought of what they think might be going on with this patient?
Yeah, so given his high respiratory rate, but he has a low pH and a high PaCO2, I'm guessing he has a low tidal volume, so he's still hypoventilating despite the very fast respiratory rate.
Okay, great. And let's see, any reason for why he's, any other abnormalities that you guys can see?
With his fever, you kind of want to wonder if he's septic. For some reason, he's so acidotic. And I don't think he would be like a chronic retainer or anything, just because he seems like he's very thin for a 6-foot man.
Okay, perfect. So let's combine both of your answers. That's exactly right. So based on his vitals and his ABG here, I'm presenting a patient that is coming in with septic shock for whatever reason. So he's in metabolic acidosis with the low pH and the low bicarb, and that's due to the sepsis. And because his body is trying to compensate by breathing off the CO2, but as Bilal mentioned, maybe he's not doing it so well. So he's still hypoventilating more than, he's still not breathing off as much as he should, and he's getting tired. So in this scenario, the patient has been compensating for a while by trying to breathe off more and more, and now it's just tired and the CO2 is accumulating and it's up to a level of like 60 now. So there are 2 things that we're looking at here, the metabolic part and the actual respiratory part. So coming from a ventilator perspective, the actual portion of this that we can intervene on is the respiratory portion of this. So he is having trouble keeping up with the respiratory compensation So with the ventilator, we can step in and help him with that. For the metabolic part, I am not going to fix his metabolic acidosis with a ventilator. I am just using the ventilator as a tool to help with the respiratory component of this clinical picture. So let's say we put him on a ventilator. He's volume AC, tidal volume 470 based on his predicted body weight, respiratory rate of 18, PEEP of 5, and FiO2 of 30%. The reason I have FiO2 of 30% here in red is just for me to, a reminder for me that usually when you kind of set an FiO2, it's important, we usually like start the patient off on like 100% FiO2, get all the oxygen in, but that's actually not good for prolonged periods of time due to hyperoxia. So that's just a reminder that you can start at 100, but if the patient's starting at like 100%, don't be afraid to down titrate until you get to a level where they're not fully at 100% all the time, just so that you're not like blasting their system with reactive oxygen species and that kind of stuff. So I'm saying they're at 30, assuming that I started at 100 and then came down as I saw that they were doing really well saturation wise on like 100, 40, all that kind of stuff. Okay, so we put the patient on ventilation, and let's say on day 2, this is his ABG and his vitals. And the thing that I wanted to point out here is that the vitals look better, right? So he's not as febrile, his hypotension is resolved, he's statting well, heart rate is resolved, he's not tachy anymore. But as you can see, it's not a perfect ABG, right? So he's still a little bit acidemic, I guess, based on these sunrise values, 7.3, his bicarb is still 19, but the PaCO2 is better now. So the question here is, do we change anything or do we keep him and watch him? What do you guys think? Chat.
Mohammed
Stay
said
the course.
stay the course, but I would poll other people. I think you have to volunteer people.
Oh no. I hate it when people say that to me.
What do you think, Bilal?
So I think given the current ABG, I'd say that probably is some level of metabolic acidosis from the sepsis, but the respiratory component has normalized, I think, because the CO2 is in normal limits. I guess the question is like, how long do we keep them on this vent setting versus should we try to wean them off eventually? And I don't know when you make that decision.
Excellent point. Excellent point. Yep. It's it depends on a lot of other things, right? If you think that they still have residual sepsis, maybe not septic shock, but they still have ongoing sepsis, then you won't make that decision. If the patient is slated to go to the operating room for a drainage or an expiratory apotomy, then you won't extubate them. On the other hand, if you think that they're looking a lot better, and this is a young gentleman, and you really think that they turn the corner and they're on the upside and match their respiratory requirements off the ventilator, then you can always try to wean them off and give them less support. It's always important to peel back the amount of support that you give, not just on the ventilator, but from a sedation perspective, from a vasopressor and vasoactive agents perspective, to downgrade it as soon as possible, as long as it's safe for the patient. But excellent thought. I think it seems like both Mohammed and Bilal agree that this is moving the right direction, and Bilal correctly pointed out that there's no respiratory component in this gas anymore. That respiratory component was probably because the patient was just working too hard to trying to match the metabolic demand of sepsis. And now that is no longer the case, because the patient is essentially you took over the work of breathing by intubating them, and it has become a lot easier to clear their CO2. So yeah, I think that's a good answer. Nancy, any other points to add?
No, that's it. That's perfect. So I just, because I thought this would get a little complicated, just a little pointer here. So one, just the point about down titrating, and two, looking at the trends. So whenever someone gives an ABG, a good question asked is like, what was their previous ABG? And also, just as Bilal said, you can't fix metabolic acidosis part with the vent. The respiratory component has been addressed. So cool. Okay. So what I wanted to do just to address different components of vents is kind of add more layers to this patient. So let's take the same patient, 50-year-old male, 6 foot, 68 kilograms, but now we give him a medical history of severe COPD. And on vitals, same thing. We're worried about sepsis, he's acidemic, and his PaCO2 is like 110 now. So same thing, we're thinking, let's put him on a vent, take over that respiratory component for him. And on day 2, we see that his vitals are better, normalized. He's still a little acidemic, and his PaCO2 is elevated, but it's at 90 now. What do you guys think? Should we tweak the settings a little bit based on this ABG? Is he fine?
Do we know what his baseline stat is?
No, I don't have that, but let's say it's 90.
Victoria, why are you interested in this saturation?
Since Nancy gave him severe COPD in red, if he normally is at 90, 92, then being at 98 might be depressing his natural respiratory drive as well.
Yeah. That comes really into view when you're trying to wean the patient who is advanced COPD and for whatever reason got intubated. Ideally, this patient should not be intubated. You should try to do everything in your power to avoid intubating COPD patients because they generally don't do well. Same with asthma patients on the ventilators. About 20 or 30 years ago, every single one of them would get intubated, and a lot of them would be harmed by the critical care that we so tried to provide. Nowadays, the non-invasive is the name of the game, and we use that very liberally and extensively. But let's say this patient was post-operative, like the patient was COPD, they needed a new hip, they went to the operating room, anesthesiologist didn't feel safe for extubation post-op, and ends up getting transferred to the ICU with the ventilator. Now on day 2, you're exactly right. You're looking at them and like, well, there's no real reason for me to be worried about this patient anymore. Whatever was happening, it looks like it's resolved. Now, my main concern is the pulse ox is 98. Does this actually helping this chronic COPD patient, or is it taking away the respiratory drive? So that's an excellent point. Although I think Nancy had a slightly different twist for this case scenario, right?
Yeah, Victoria, we'll talk about your concepts in like 2 slides. So good job. But yeah, basically the only thing I wanted to talk about this was kind of hammering in the same thing where you're looking at the trends here, but the fact that he does have COPD, yeah. So patients with COPD tend to experience something called air hunger, where they're really like gasping for air. They feel like they just really need to put way more work into breathing. So in order to help with that, we can increase the tidal volume to make breathing a little bit easier, a little bit more comfortable for them on the ventilator. So that's one thing that you could tweak just based on the patient's history as a preventative measure, nothing to do with nothing to do with the abnormal values that I'm showing you here. Obviously, if they're like wheezing, gasping for air, trying to breathe over the vent, those are all other signs that maybe that the vent settings aren't good for them. But I'm just talking about this from like a preventative measure based on the history that you now know. The thing that I wanted to point out to avoid was increasing the respiratory rate to accommodate the elevated CO2 level. So kind of what Victoria was hinting at, that this elevated CO2 may be normal for him. Maybe he doesn't set at a normal level like someone with normal lungs. So we shouldn't be chasing down a normal pH and a normal PaCO2 just to get rid of the red arrows. We should be thinking about the whole clinical picture. Okay. Any questions about this one?
I probably have said this before, but whenever you think about respiratory rate or tidal volume, always remember to use them as a product, as in they represent minute ventilation, and you should always think of them as such. So you should not think of, when you were looking at the ventilator and trying to make a decision, do not think of it as, oh, what do I do with the respiratory rate, or what do I do with the tidal volume? always think of them in conjunction together and then decide whether you need to adjust them. Because as Nancy was saying, in this particular patient, if you try to do the opposite, you may get the same minute ventilation, but you definitely hurt the patient by not allowing them to.
Oh. Awesome. All right, so one more layer that I wanted to add to this. So let's say you have the same patient, 50-year-old male, height of 6 foot, but now he weighs 200 kilograms instead of 68. And we're going to keep the severe COPD here just for educational purposes for this example. All right, so you do the same thing. You put them on, you get the ABG, they're acidemic, I call them 18. You put them on a ventilator, volume AC 470 based on their ideal, respiratory rate of 18, PEEP of 5, and FiO2 of 30. And on day 2, it looks like vitals have normalized, and the rest of their ABG actually looks to be pretty normal as well. Is there anything you guys would want to point out based on their history or their body weight?
I think the tidal volume is inadequate given their body weight. I'm not sure how the recommendations change for different pathologies, but isn't it usually like around 6 or so, like mils per kg?
Okay. Yeah, so we can definitely talk about the tidal volume. Yeah, so the recommendation is 6 to 8 based on their ideal body weight, not on their actual body weight. So again, like as we said, even though the patient gets very, very big, their lungs don't increase in size to accommodate that. So the tidal volume here would be 470 would be adequate for his ideal body weight, but because of the COPD, I would consider increasing the tidal volume or adjusting the ventilation as we discussed in order to prevent air hunger. So let me just put up my pointers here to, yeah. So here, I would touch the tidal volume, but not because of his weight, because of the COPD component of this. In order to address the weights that you're pointing out, this is also something you guys nailed on the pretest, is that the total compliance here is going to be determined by the actual lung compliance, like the trach, unless they have some sort of disease going on that's making them less or more compliant, and also chest wall compliance. So in this case, if a patient is 200 kilograms, there's going to be a lot of weight coming down on their chest. That's going to make it harder for their lungs to, or harder just in general for the respiratory system to move air in and out effectively. So to help with that, usually for patients with a higher BMI, we would increase their PEEP to counteract that increased chest wall pressure. So with the increased PEEP, you provide more back pressure to keep those airways open against the crushing pressure of the rest of their body. So for this one, we would touch the tidal volume for the COPD and increase their PEEP to accommodate for the 200 kilogram weight. Does that make sense? Well, does that make sense?
Yes.
Awesome. Okay. So yeah, big point here, ABG looks fine, but you still have to think about the patient's actual clinical picture and their weight for other settings of the ventilator. Okay, perfect. So last acid-base case, I promise. This time, let's go back to the patient in the first scenario who was 6 foot, 68 kilograms, no medical or surgical history. We intubated them after they came in and we were concerned for sepsis, and they've been doing really well in the ICU for some time, and this is their ABG now. So after being on volume AC 470, 18, 5, 30%, they now have a pH of 7.5 and a PaCO2 of 25. So what I'm trying to get across here is respiratory alkalosis, where basically the patient is a little bit too comfortable on the vent. We've done such a good job of providing them with the correct care and taking over the work of breathing for them, that now the patient's drive to breathe is kind of dampened a little. So they're becoming alcoholic. And what we do is each day we do something called a spontaneous breathing trial and a spontaneous awakening trial. So we go light on the ventilation settings, see how the patient does. And also, because many of these patients are in sedation, we lighten up on the sedation as well. So that you can really see how the patient is doing without all these extra components that we've added to their care. So let's say we do that for the patient. Vitals are, the temperature is still afebrile, but now after you kind of take away the extra support that you've been giving him, his heart rate jumps to 90, his respiratory rate drops to 9, and he's now setting at 88. What would you guys do? Would you go back and go full vent settings, or would you kind of wait and see what the patient does? Mohammed, what would you do? Never mind. Anybody? No?
Victoria, I'm nominating you to answer this.
So when Nancy, when you first gave the case, I thought maybe the respiratory rate was too high for him because it looked like he was just breathing out too much CO2. So I haven't done ICU yet, but I would maybe see how he does, and maybe he'll automatically raise his rate now on his own.
Yeah, so this is a pretty common clinical scenario where we've been overtaking the work of breathing for this patient, and when we finally take them off, they're just not used to breathing on their own. So in this case, we would wait and see, allow the patient to build up CO2 in order to stimulate that breathing center of their brain. So there's no need to go back on the vent right now, or like to go full settings on the vent because they're not breathing as well as you thought they were on the ventilator. And you do get an ABG here, and I'm not expecting a perfect ABG here. So I like put kind of shady values that are like right on the border of all the ranges. Because if you just wait and then let the body accumulate that CO2, start breathing on their own, they're going to eventually trigger that breathing center and be able to do better. If the ABG does swing in like the complete opposite direction, like this guy is in now respiratory acidosis and just not breathing at all, then yes, something is wrong and we should go back to full support. But this is okay.
Yeah, the package of SAT and SBT is to pause the sedation, let the patient wake up, and then do the SBT. Sometimes the nurses would do the SAT and they pause it and then simultaneously go on in the spontaneous breathing trial, thinking that the patient will wake up. And if you have taken over all the work of breathing, then the patient would not work. The way I like to think about it is, think of assist control as 100% support and the spontaneous breathing trials as 50% support. So when you go to a lesser amount of support, then it might be too much for the patient, in the sense that even with half of what amount of support you are giving, they don't feel the need to breathe again, because with a little bit of the way the machines work is they initiate the breath by showing a little bit of effort, and then the rest of the breath is being delivered by the machine, so they don't do anything else, and they may not feel the need to breathe more than 8 or 9 times a minute. So if you give them a little bit more time for the CO2 to accumulate, then their brains would kick in. So you're essentially downgrading them in terms of support to stimulate them to breathe again. To Victoria's point, not just the numbers that you're manipulating, but in totality of ventilation, you're also adjusting how much support you're giving, if it makes sense.
Any questions on that? Okay. All right. And now done with acid-base. this is just a summary of all the slides previously of what can go wrong. I'm not gonna read them all out for you now. And this is the last section, just going to this purely clinical. I know it's getting a little bit late, but this part is fast. So there's this acronym that people often use called DOPES dots to help you go through an algorithm, if you will, of things that commonly go wrong with ventilators and what to do about it. And they also use this thing called like tube sound sats. So just a way to follow. If something is going wrong, make sure the EP tube is in place, auscultate the chest, and ensure that the patient is still setting adequately, because if not, you're going to have to go to more drastic measures to actually oxygenate them instead of fiddling with the settings. Okay, so the way I did this is that I took each of these letters and created just a very simplified clinical scenario for you guys. And then at the end, I'll just reveal like what the acronym is, and then we'll be done for tonight. So going to once again ask for participation. So let's say you walk into the room and the ventilator is giving you an alert of low pressure. And again, very simplified, these are the two graphs that I want you to look at, and I'll reveal more information as we go forward. So Ashna, what do these graphs look like to you? Are they normal? Are they messed up?
It looks like it's messed up.
Yeah, okay. Let's look at the, go ahead.
I mean, I actually don't entirely know. Is there too much of a difference between the, I don't know, is this like a kinked tube kind of scenario? I'm not really sure.
Not quite. The king tube scenario that you're thinking of would be like kind of like this and then down like that, showing a ton of airway resistance. I'm showing a normal airway resistance here. But you're right in that both of them are abnormal. So just for sake of time here, so this one I'm just showing like a blank end-tidal CO2. There's no waveform at all. And for here, these are a low peak and a low plateau pressure. I think normal would be like below 40 for a peak. And right now you're not even getting to like, 10 right here. So in terms of what's going on with this patient, you take a look at the patient, and last night their tube was over here. And this morning when you see them, the tube is out to here. Nurse reports agitation overnight and they're satting at like 70%. So in this case, it would just be displacement of the EP tube. You're not accurately measuring the end tidal, and something's wrong so that the patient isn't even getting ventilated adequately to the point where you can generate a full pressure waveform. Sorry, looking at the, okay. All right, and for high pressure, let's say you walk in, and this is your warning, and these are your end tidal and pressure graphs. What do you guys think? Oh, we only have 2 people left. That's really sad.
I assume I cannot answer.
Mohammed, do you want to take this one in the chat? Okay. Okay, we'll just run through these. So this one is showing a normal end-tidal CO2 graph, and this is showing an elevated peak pressure, a ton of airway resistance, and then a pretty low plateau pressure. So Ashna, this is kind of what your waveform would look like for a king tube scenario. And you look at the patient, they have decreased breath sounds and a ton of oral secretions. So the diagnosis here would be obstruction of the tube, just another way of increasing your airway resistance. Okay. So the next one, I'm showing now there's a widened gradient between your PaCO2 and your end tidal, which is usually they go in the same direction, remember, but this is showing a widening of that arterial alveolar gradient. And also now an elevated peak pressure and an elevated plateau pressure. This one, you ask what happened and you find out that a central line was recently placed. You take a listen, breath sounds are absent on the right, and they're satting out at 82. So the diagnosis for this one would be pneumothorax. Okay. This one, patient is disconnected is the warning that you see, but your patient is 65-year-old female with myasthenia gravis coming for MG crisis, and you notice that the patient is still connected to the vent, but now you see that there's a sudden change in her vitals. Her heart rate is now at 100 and she's setting at 79% when before she was fine. So here I have a PaCO2 of both being elevated, so which means that she's hypoventilating. She has increased CO2, and also none of her waveforms are there on the ventilator. So this one is kind of, I don't know, it's kind of like a cheap one, but it's just equipment malfunction. The point I wanted to get across here was just that this is like a purely muscular reason for why a patient would need ventilation. And even though things look like they're still connected, if the ventilator is saying that something's wrong, it's more just like it's just that the equipment isn't working. And yeah, that's basically it. I have no other deep words to say about that. Okay, and then this is the last one. You're getting another high pressure warning. The gradient is again increased between your PaCO2 and your end tidal. And I'm sorry for the really bad drawings, but these are the curves that you would see in your ventilator. And your patient is 65-year-old male, extensive smoking history, 2 packs a day for 40 years. And these are your ventilator settings. And this is just me trying to recreate the auto PEEP situation, or the stacked press. So as you can see, this is the flow suddenly reversing at the end of expiration, and then the ventilator taking over and shoving the next breath in. The pressure slowly increasing, and then the volume also slowly increasing. All right. So if you were to put this all into the acronym, this is what it would be. This doesn't correlate like one-to-one. This is just different problems and solutions that come together to say dopes and dots. And then, yep, that's it. Any questions from the 2 survivors of this lecture? Okay, great. Are you two okay?
I just wanted to say you did finish on time. We just started a bit late.
Okay, cool. Are you two cool with the post test?
Sure.
Okay, awesome. Thank you, Ashna.
How does it feel, Ashna, to hold 50% of the vote?
I feel powerful.
Yep. A veto.
Ashna, you are powerful. You're an independent woman. Okay. Wait, I need to know your pre-test. Okay, I'm gonna assume that Santa round 2 is Santa. Okay, awesome. Test and go. Okay, yeah, so for this one, this is the reliable one on the left because even though it looks kind of funky, if you track it with the heart rate, it's actually lining up with each, like your pulse. This one wouldn't be unreliable because even though it looks pretty, it's actually not correlating to the patient's actual heart rate at all. Does that make sense? Okay. Mhm. Perfect. Awesome. Okay. Yeah, so this is the example for the curves for someone with like auto sleep or the stacked breath or the dynamic hyperinflation. And here the answer would be to lower the respiratory rate because the problem here is that the patient doesn't have enough time to finish expiration. So by lowering the rate, you would be giving them more time to finish that before the next breath started.
And this is because the I time doesn't change. The inspiratory time stays the same. So you get longer time to exhale.
I think you guys got that one on the pre-test as well. Nice. Okay, last one. Great. Okay. Thank you guys. Any questions or feedback or
I
anything?
think Mohammed had a question about,
Yeah,
I think it was sixth or seventh question. I'm not 100% sure.
yeah. Let's see if I can get it. Okay. Mohammed, which question was yours for?
I think it was
Sixth or
either
seventh?
sixth or seventh. Seven.
Seventh.
He
Okay.
says seven.
The following is the yellow also correct? Decrease.
He changed his mind to 6. I was right the first time.
Okay. 6. Full
Full title
volume.
I'm stopping. Can you open the graph?
Yeah. Let's see.
No. The reason is the positive or the upward side of the flow is the inspiratory component. All the downwards are expiratory. So the breath has already been delivered. Does it make sense? Yep.
Yeah. Okay.
This graph just shows you the directionality of flow.
Sorry.
Very good.
Okay. Well, but you're the only person left, so I'm going to stop recording.